Hey everyone, it is Professor Lee, and this is the Key Point lecture for Chapter 28, Evaluation and Management Codes. So we begin with some E&M basics. Evaluation and management are more commonly called E&M codes, and they describe patient encounters with a physician for the evaluation and management of a health problem. Each setting or purpose has a separate category of codes and a specific set of criteria for selecting the correct code. So we're going to learn some more about that as we go through this key points lecture. During the evaluation portion of the encounter, providers gather information and determine the nature and cause of the chief complaint. That includes things like asking questions about the problem and performing a physical examination. During the management portion of the encounter, providers formulate a treatment plan, also called medical decision-making. So some other things to know about E&M codes is that they are assigned based on unique criteria that have specific definitions within Cpt Guidelines. Those definitions include the setting, where the service is provided, such as an office, outpatient, hospital, emergency department, or nursing facility. This is also called the place of service. The second criteria is the patient type, and that's whether the patient is new or established. And the third is the level of service, and that is the complexity or length of service provided based on the nature of the presenting problem, the history, the examination, and the medical decision making. The process to look up an E&M code is much like it is for any other CPT code lookup. You're going to search the CPT index for the main term, evaluation and management, and then you'll select the first level modifying term for the category of service, such as hospital services or office and other outpatient. You will then cross-reference the code range shown in the index to the tabular list and identify the criteria that differentiates the codes, such as key components or time, and then finally select the level of service. There are 4 guidelines that you have to consider when determining the level of E&M service being provided. There are E&M section guidelines, category special instructions, and then there are 2 sets of documentation guidelines for evaluation management services. One is from 1995 and the other is from 1997. Okay, sorry, I had to pause you for a minute. My daughter and grandpuppy came over and I had to turn the fan on because it's like 90 degrees in my house right now. So, back to those different types of documentation guidelines for E&M services. Again, there are 1995 and 1997 documentation guidelines. Physicians may use either the 1995 or 1997 documentation guidelines as criteria for any E&M encounter. They can use 1995 for one patient and then turn around and use 1997 guidelines for another patient. However, they cannot pick and choose from both sets of guidelines for the same encounter. So if they're using 95 guidelines for a patient, then they have to use 95 guidelines all the way through, but they for that visit or for that encounter, and the same applies to the 1997. So they can't pick part of 1995 and part of 1997 and put them together for one patient for one encounter. The CPT guidelines appear at the beginning of the E&M section and provide information that applies to all codes within that section. All of the information used to classify E&M services, the setting in which the service was provided, the type of patient and or frequency of the encounter, and the criteria used to determine the level of service, all of those must be abstracted before a code can be assigned. So the divisions of the E&M section are called categories and subcategories. This is different than subsections and subheadings, which is the case in most of the other CPT sections. So E&M uses categories and subcategories. A category is the first level of division in the E&M section. It identifies the setting of the service, so the place where the service took place. The E&M section provides 21 categories of codes, with each category associated with a specific setting. So let me show you, talk to you, sorry, not show you. Let me talk to you about some of the commonly used categories for outpatient settings. So an office or other outpatient setting is a non-residential medical facility to which patients come for several minutes or several hours at one time. The category office or other outpatient services code ranges 99201 to 99215, identifies services to diagnose or treat health problems and symptoms. The category Other Outpatient Consultations code range 99241 to 99245 identifies outpatient encounters in which a physician is requested by another physician to provide a professional opinion on a specific problem. The category Preventative Medicine Services, which is the range 99381 to 99429, identifies general comprehensive checkups performed to maintain health, identify risk factors, and provide appropriate counseling rather than to manage acute or chronic conditions. Other E&M services provided in the office or outpatient settings are life and disability insurance examinations, post-operative follow-up visits, anticoagulant management, and critical care sometimes too. There are two types of services that occur in a hospital facility, but they are reported as outpatient services because the patient has not been admitted as an inpatient. And those two are the emergency department services, which is code range 99281 to 99288. That set of codes identifies services provided in an organized, hospital-based facility that is open 24 hours per day and that provides unscheduled services to patients requiring immediate medical attention. The second type of service falls under the category Hospital Observation Services, that is code range 99217 to 99226. These services this code range identifies services provided to patients placed on observation status who have not been formally admitted to the hospital as inpatients because they do not meet the necessary criteria for hospital admission. So it's important to remember those two categories for hospital facilities that are also reported as outpatient codes. The commonly used categories for inpatient coding. The inpatient hospital E&M services include several categories for inpatient hospital services, including routine visits, consultations, and critical care services. The category hospital inpatient services code range includes 99221 to 99239, classifies inpatient admission, continuing follow-up visits while an inpatient, and discharges. If you are using codes from this range, you will likely need to apply a HCPCS modifier. The modifier distinguishes the admission encounter from the initial patient visits by consulting physicians. The category Inpatient Consultations code range is 99251 to 99255, identifies consultations provided to hospital inpatients, residents of nursing facilities, or patients in a partial hospitalization program. So these are people who have been admitted, they've met the criteria, they are inpatient in the hospital, and we are billing for consultations provided to those patients. The third category, critical care services, has an age stipulation on it. So the code range for ages 6 to adult is 99291 to 99292, and those identify medical treatment provided for an illness or injury that impairs one or more vital organ systems and also presents a high probability of imminent or life-threatening deterioration when that treatment can be provided in any location. So critical care codes report the time spent providing services services. Remember last week we talked a little bit about time units. The CPT manual identifies the services that are included in critical care time and that should not be billed in addition to the critical care codes. So to give you an example of that, if a patient is being treated for 20 minutes as a critical care, that critical care 20-minute billing code may include things like resuscitation or placing a trach or anything like that. So those are just some wild examples of what could be included in that code. It's basically billed by time, and then there are clear definitions of what is included in that code that cannot be billed separately. So the CPT provides specially designated codes for several newborn services as well, including normal newborn care, intensive care, and delivery attendance or resuscitation. So just be aware of that. So moving on to this third point over here, established versus non-established patients. So this is an important factor in helping to select the appropriate code for E&M services. The patient type or status identifies whether the patient is new or established based on clearly outlined CPT definitions. An established patient is one who has received professional service from the same physician or another physician in the group of the same specialty and subspecialty within the previous 3 years. So to clear that up for you, if a patient has went to a individual provider or they went to a doctor's office where there's multiple providers and perhaps they saw one doctor, their normal physician one time, went back, saw the nurse practitioner a couple of years later, and then saw another physician or partner in that same practice within 3 years, that is an established patient, regardless of who they are seeing there at that practice. A new patient is one who has not previously received services from a particular physician or group of physicians in the same specialty or subspecialty. So that would be a new patient. So if they have not received services from any provider in that practice, then they would be a new patient. Now, if they have been out of that practice for 3 years and then return, they would be considered a new patient upon their return, so long as 3 years have elapsed. The Enm categories, inpatient hospital services, hospital observation services, and nursing facility services divide codes based on whether the encounter is initial or subsequent. Initial encounters refers to the first encounter by the admitting physician during the current admission. A subsequent encounter refers to a second or later encounter by the admitting provider during the current admission and to all encounters by other than the admitting physician. So there's a little bit of differentiation between inpatient and outpatient. So outpatient uses new or established, inpatient uses initial encounter and subsequent encounters. The CPT definitions for initial and subsequent encounters differ from those that are used by the ICD-10-CM manual for assigning the 7th character for an episode of care. So I know you guys don't know much about ICD-10-CM right now, but it is important to remember that the CPT definitions for initial and subsequent encounters are different than those that are used for diagnostic coding. Okay, so we're moving down to the bottom, the key components to define complexity. So there are 8 E&M categories that define the level or complexity of service provided based on a set of 3 key components. History, examination, and medical decision-making are the 3 key components. So in addition to those 3 key components, E&M service also have 3 contributory factors that are important but not required at every encounter. So I want you to keep these in the back of your mind. Those include counseling, coordination of care, and the nature of the presenting problem. So we have to meet the 3 key categories, 3 key components. And in addition to those 3 key components, we could also need information about counseling, coordination of care, or the nature of the presenting problem, but those additional components aren't always required, like the history, exam, and medical decision making are. Enm categories that do not use the three key components to establish the level of service define code levels in other ways, such as the amount of time spent by the physician or the patient's age. Okay, so the first key element or key component is history, and that refers to the discussion between the patient and the physician regarding several areas that could provide information regarding the patient's medical situation. So elements of the history are the chief complaint, a history of present illness, a review of systems, and the patient's past family and social history. So during the chief complaint, that is what brought the patient in today. A history of the present illness is where the doctor would ask questions like, how long have you had these symptoms? When did you first notice them? Did things make them better or worse? A review of systems is where the doctor goes through the body systematically and observes and measures different parts of the body systems and their functionality. The patient's past family and social history include things like their sexual partners, their smoking and drinking history, any drug abuse history, whether or not their mom and dad had diabetes, whether their grandparents had died of cancer, things like that. These elements are discussed a little bit more in detail later on in this chapter, so if you need more explanation for these, you can always read further into the chapter and get some information there. The second component is examination. The physical examination is objective based on the physician's exam of the patient. So the 1997 guidelines present a bulleted list of elements in each body system that potentially can be examined for the general multi-system examination. It also defines 11 single organ examinations as well. Examination elements are also available further in the chapter in more detail, so if you need more detail, read through that section in this chapter in your textbook. The third component is medical decision making. So medical decision making refers to the complexity of establishing a diagnosis and or selecting a management option. And there are three elements to medical decision making that you have to know about. The first is the number of possible diagnoses and or the number of management options that must be considered. The second is the amount and or complexity of medical records, diagnostic tests, or other information that must be obtained, reviewed, and analyzed. The third is the overall risk, which includes the risk of significant complications, morbidity, mortality, and any comorbidities associated with the patient's presenting problems, any diagnostic procedures performed, and then lastly, management options. So again, there is a further explanation in the chapter that I encourage you to read more in full, but to give you a general overview of medical decision making. If a patient comes into the doctor's office and they are complaining of a headache, there are a million things probably that could be the possible cause for a headache. And so the doctor's going to have to differentiate the reason for the headache, what the cause may be, and then that would help him arrive at a selection of possible diagnoses. If there was a lot of history with this patient and this headache, say they've been having migraines for 10 years, that could be, lead to complex evaluation of medical records, some extra diagnostic tests, things like that. And then whether or not that severe migraine is incapacitating to the patient in any way, if they are at risk for significant complication, if they're at risk for dying, if they're at risk for developing further illnesses because of that, then all of those things are considered when selecting the level of medical decision making. So just keep that in mind. I definitely encourage you to read that section well. The last bullets over here are the ways in which we need to meet those three key components: history, exam, and medical decision making. So there are 8 Enm categories that define the level or complexity of service provided based on a set of 3 key components. Like we just said, the history, the examination, and the medical decision making. And each of those key components can be performed at varying levels of complexity. So what you need to know is that when an Enm code requires 2 of the 3 components, One component in the medical record can be lower than one listed in the code description. However, two must meet or exceed the levels listed in the code description. When codes require all three components, then all three components in the medical record must meet or exceed the levels listed in the code description. For codes that are based on three key components, which means that all three key components have to be met for history exam and MDM, or the medical decision making, those will often require additional abstracting from the medical record to determine the actual level of each component. This is accomplished by following detailed instructions in the 1995 and 1997 documentation guidelines. So remember that you can always refer back to those 95 and 97 documentation guidelines to help guide you through the code selection process, especially in this E&M section. Okay, that is all I have for the key points for Chapter 28. As always, reach out if you have questions. Otherwise, I will see you guys next week. Take care, everyone.